Hello, everyone. Welcome. We are live. Let's get that music off there. Welcome, everyone. Please drop your questions into the chat. My name is Giselle. I'm a psychiatric nurse practitioner, and this is the Level Head in Mind channel where we provide you with mental health education. So, tons of videos on different mental health treatments, medications, as well as holistic treatments for mental health. So, if you have any questions regarding mental health or your mental health treatment, please drop them in the chat because I'm answering them live today. All right. So, with the order of answering questions, just so you're aware, we will take priority for members. We have a channel membership. It's $4.99 a month. And those channel members will get priority answers to their questions if they have any and they are in the chat. Then we will do super chats and then go in order. So that is how we'll be taking the questions, just so you're aware. Please no spam. And I do have my moderator, Raul, helping me here today, who also is the editor of our videos. So we can all thank Raul for being here and making this possible as well. So I am under the impression we have some questions, so we'll go right ahead and start answering your questions. All right. Kathy. Hello, Kathy. Let me see about getting that banner off of there. Okay. So Kathy Tarleton, welcome. I have PV, VWD, von Willebrand's polycythemia vera. So, okay, so some blood dyscrasia is going on, and you're on baby aspirin. Is there an antidepressant I can ask my doctor about that would not have blood thinning effects and interact with the aspirin? So, yeah, serotonin is going to cause when we have SSRIs or anything that's modulating serotonin. Unfortunately, there is a risk for bleeding because it aggregates the platelets. So medications that are antidepressants that wouldn't do that would be like bupropion. That's a norepinephrine and dopamine reuptake inhibitor. So no serotonin action there, and risk for this bleeding or interaction. And the others that I can think of would be to mood stabilizers if you wanted to go that route, like lamotrigine. Lithium, lithium orotate would be nutritional lithium if you wanted to go more of a holistic approach to help with depression. And I do have a link for information, particularly on lithium orotate and how it really helps with all kinds of mental health ailments, and that could be an option. So yeah. Unfortunately, though, there aren't many options when it comes to, some blood thinning issues. Now, some doctors, if you have a hematologist that you're working with, some will say, hey, if we monitor your labs and that we can do an antidepressant, but you would have to run it by them, of course, and get their approval before starting one if you feel like starting an antidepressant is the right choice for you. But as I always say, always make sure you're doing your skills first, skills before pills. Try therapy first before anything, and then also look at nutrient deficiencies and try replacing them. Vitamin D, very common. B12, folate. If you're going to check B12 and folate, always check your homocysteine. I get a lot of providers or patients that come to me that providers have, I did my labs and they check their B12 and folate without a homocysteine. You need homocysteine when you check B12 and folate, people. So make sure that they're adding in that homocysteine, because you don't get the whole picture if you don't know your homocysteine. So yeah, checking homocysteine with your B12 and folate levels. Also, the vitamin D, I would look at your omega-3s as well, do an omega-3 check to see if you're deficient in any of those nutrients and that those could be, an issue. Also iron, too much iron or too little iron can also be a factor with depression. So definitely start there. But those medications, like I said, initially bupropion or Wellbutrin, or you could go towards like mood stabilizers like lamotrigine or lithium or lithium orotate, a nutritional lithium, low dose. All right. Buffy. Hi, Buffy. Welcome to the channel. I have bipolar 2 and take Lamictal 300 milligrams and Vraylar 3 milligrams, but you're still feeling depressed. What other options would you consider in this case? So, okay, definitely 3 milligrams of Vraylar, you're at the top there, and lamotrigine, you're basically maxing out your top with these medications. Um, when I get people that are stuck like this, the first thing I always do is a full mental health labs panel. And so I have a video on the basic labs for mental health that I would start with and then kind of dig from there, because most likely you're also dealing with some nutrient deficiencies and why these things maybe aren't working as well as they should. Um, if you wanted to look at conventional medications and switching, you could look at lithium as another option to Lamictal, and perhaps changing that over. Um, if Lamictal's working well for you and you want just something as a another mood stabilizer, like in the antipsychotic world, like Vraylar is, not sure if you have tried Latuda instead. Some people will respond better to that. Caplyta is a newer one that people are, responding better to with less side effects. That one you would need to get approved to get it covered by your insurance. So if you're wanting to go that route with conventional medicine, perhaps switching to either a different mood stabilizer like lithium, which tends to be really, really good for bipolar, all the stages of bipolar 1, 2, even the mixed episodes. And then, if that's not helpful, or if you're looking for something different, you can go down the list of all of the atypical antipsychotics or mood stabilizers, but just be weary of the ones that like the older ones that cause, metabolic syndrome, weight gain, and those types of things. So sticking more to like the Vraylars, Latudas, Caplyta, Brixolti, Abilify, those would be looking at, trying to minimize those side effects that come with the older generation, and even some of the second generation antipsychotics, but may still give you benefit. So yeah, that's what I would be looking at. If Vraylar isn't helping you, I'd be looking at probably Latuda, adding that in there if Lamictal was doing something, but it stopped. You can technically too max out Lamictal a little more if you can tolerate it. You can go up to like 400 milligrams if it was helpful. That is something that can be done, and you can split your doses. So you're doing morning and evening dosing on that too. So that is another thing that you could try as well, is trying to get a little bit more from the Lamictal if it was helpful at first. I'm just not sure like where you started and all the things you've tried. I don't know your whole story, but yeah, definitely first I would go with labs, see what else is going on there and why these things stopped working or aren't working for you before making these other changes. And then once we get those under control and make sure your nutrients are repleted, then sort of looking at what else we could do to help with the symptoms that you're having of bipolar. All right, Skelly MC, hello. What's your experience with Trintellix and GAD, panic disorder, and agoraphobia? Well, Trintellix, I've used it quite a bit with GAD and depression. Wouldn't be my first choice for panic disorder or agoraphobia. And when it comes to patients that I have on Trintellix or have been on Trintellix, I'm trying to think if any of them have panic disorder. Some of them were having some panic attacks with their GAD that were presenting more as anxiety attacks, and Trintellix was helpful there. But, as far as it helping with panic disorder and agoraphobia, it may be helpful in those cases, but therapy is really first line treatment, and getting as far as the underlying thought processes and doing some good CBT or trauma focused therapy if because a lot of times panic disorder and this agoraphobia is related to some type of fear or trauma, an event that has occurred. So I would say therapy is first line treatment. And if Trintellix is helping your anxiety symptoms and minimizing, some of this, that would be beneficial. Um, you could also do some PRNs for panic disorder, things like I mentioned the non-benzodiazepine alternatives, things like clonidine and um, propranolol and clonidine as well. Well, both of them have been shown to help with lessening the HPA axis stress response, fear response, and a lot of that is seen in patients with, panic disorder and agoraphobia. So those could be alternative options. Most conventional psychiatrists are going to go right to the benzodiazepines, but if you know me and you've seen the channel and the videos, then you know that that is not an option that I ever like to really go to. And if I ever do, it's very short term. And I have to mention the risks involved with those medications because they have the dependency factor, tolerance factor, but then when it's time to come off of them, they're difficult to come off of. So you just have to be careful with those benzodiazepines. But as far as Trintellix being able to help with that, it may or may not. I don't really use Trintellix in those cases, but for GAD, absolutely, especially GAD with with depression and anxiety attacks, using Trintellix in those cases, I've seen it work very, very well for patients with that type of presentation. Okay. TSX, hello. Okay. I use Cymbalta for the last years, but the effects is the complete opposite now than when I first started. It's giving me mood swings over the day, feeling tension in my body a lot. So you're having an opposite effect. Now the doctor wants to put me on Prozac, but I'm scared of the transition. Will the Prozac take the effect from Cymbalta, or do I have to go through all the side effects at the beginning? Yeah. Lyrica beside it. Oh, here we go. This is conventional psychiatry 101. Just throw more meds at you. Okay, so you're having a paradoxical effect of Cymbalta, dealing with some agitation, some restlessness. It's doing the opposite of what it's supposed to do, mood swings. So my first thing, especially when I see mood swings with an antidepressant, I want to rule out bipolar, make sure that that's not a factor. Um, and then once I've ruled that out, then of course, if you know me, I'm going to look at labs and make sure we're ruling things out like zinc deficiency, copper overload, looking at all the other labs as well that I check for, magnesium, vitamin D, omega 3s, B12, B9, et cetera, et cetera. I go through all of that. Omega 3s as well, especially for mood swings, irritability, and those kinds of things, to make sure we're not seeing deficiencies there that could cause this type of reaction. And then, I definitely would say, let's get off the Cymbalta. You have to be careful with getting off of Cymbalta. So I could see why the provider would want to switch you to something like fluoxetine or Prozac, because the transition from doing a switch like that would be a lot easier because Prozac has a long half-life. So when your doctor's switching you over, there is a switch, when you switch over, you slowly, you taper off of the Cymbalta as you're bringing in the Prozac so that you don't just rip the Cymbalta away. If you were on the Cymbalta for anything more than 3-6 months, we would want to, kind of make that transition accordingly. And but as far as being scared of the transition and going through all the side effects, I can't predict whether or not you're going to have any side effects with Prozac, because I hate to break it to you, but there are people that have paradoxical effects with Prozac. And I also don't know whether or not you were reacting to the norepinephrine in Cymbalta Sometimes people, especially as you're increasing the dosage of Cymbalta, will have a paradoxical effect to that and start having agitation and restlessness. So not really good, obviously, for patients who have anxiety. And it sounds like you're dealing with some anxiety right now as well, especially being afraid. And then, your doctor wanting to give you Lyrica. Now, Lyrica is a gabapentinoid, one on the list of just as much as benzodiazepines affect you long term. Lyrica would also be one of those that can have similar issues. And so, yeah, though there is some efficacy for it to help with anxiety, you want this to be a short term thing while you're making the transition, maybe just a couple of weeks. Because if you end up on that long term, you're going to have a hard time, once that stops working, or if you start having issues or side effects with it, coming off of Lyrica can be brutal. So definitely, those are all things to, talking points with your provider to discuss. And like I said, I can't really predict whether or not transitioning to the Prozac is going to be better for you, but Prozac doesn't have much action on norepinephrine directly. So the transition may be better for you. And if you tolerated Cymbalta in lower dosages, and then as you went up and you had this reaction, it could be based off norepinephrine, but I don't know the whole story. I don't, you're not my patient. So just trying to give you like a broad general things to talk to your provider about, just because there are a lot of things to consider here. But if you were to come to me, I would want to look thoroughly at your labs first and see what else is going on, and figure all of that out as well, and make sure that your nutrients are repleted and that we're not missing any medical conditions like hypothyroidism, hyperthyroidism, any autoimmune conditions that could also present in those kinds of ways, or even brain inflammation. I mentioned homocysteine, which can be neurotoxic. So that's always one that I check with the B vitamins. But yeah, you want to make sure you're checking all of those factors as well, because that could also be something that could trigger some of those paradoxical effects. And you're blaming it on the medication, but maybe it's actually something going on internally. And then, of course, we don't want to dismiss life factors and things that could be going on in your life that could, maybe it's a stress response you're having to everyday stressors or trauma or something like that. So therapy would also be something to consider there, to make sure that we're dealing with any of perhaps trauma that's being stored in the body, and doing somatic work, vagus nerve work. I talked about that in my video on the vagus nerve that I just recently did. So perhaps looking into doing some of those things just to get that HPA axis regulated again and turned down so it's not overactive. Those are things that you can also do. But definitely talking to your provider about these points of adding in Lyrica and how that can create more disruption in someone who's already agitated or having anxiety, or it may help for a short time and then may stop working. And then if you have to taper off of that, that could actually end up being, that can end up in benzo-induced neurological dysfunction state, which you don't ever want. I would never wish that upon my worst enemy. And I have videos on those topics if you want to look at that. So have all this discussion with your provider in those regards, but I can't really predict for you whether or not that transition is going to be good for you, because everyone responds differently to medications. And I don't really know what you're working with biologically speaking, what's under the hood. Because if you're missing, important nutrients and key cofactors, to even make your neurotransmitters to begin with, then nothing we give you is going to really be helpful. All right, Mark. Hi, Mark. I take 40 milligrams of Prozac daily, but I'm still struggling with anxiety. Are there any additional medications or treatments that can help with both anxiety and depression? Yeah. So traditional, conventional psychiatry here. If you're still struggling with on Prozac with anxiety, you could add buspirone, if we're talking about, traditional things to kind of help. If you wanted to switch to something that's going to be a little heavier, helping with anxiety and depression, something like vilazodone or Vibrid could be helpful here, especially if you were responding well to the SSRI. But and that would be like adding it, an SSRI with buspirone just in one medication, because it has that partial agonism of serotonin there with buspirone. Or you could just add buspirone to the Prozac to see if we could get a little bit more help there with the anxiety. When you do add buspirone, you would want to be adding it twice a day. So that's something to talk to your provider about, if you want to try that. And also, as I mentioned before, therapy, of course, to figure out what's going on. Yeah, Wellbutrin. So you've tried Wellbutrin, Venlor. I'm thinking that maybe it's venlafaxine, Zoloft, and Trintellix. Okay. Wellbutrin would definitely can make more anxiety worse, be more for depression. Venlafaxine could help. Sertraline, could be one that helps. And of course, Trintellix, we just talked about that, serotonin multimodal antidepressant. So if you've tried all of these and they're not working, again, that always brings to question in my mind, why aren't they working? Why aren't they helping? And what's going on under the hood? So if you've heard me speaking to, the other questions, making sure that you're checking your nutrient deficiencies. And if Raul hasn't already put the link to that video there, Raul, if you want to go ahead and find that Basic Labs for Mental Health video, it sounds like a lot of people could probably use, to watch that video, write down, the labs that I do, and get an idea of what they should be looking for. Because oftentimes cofactors, to help these medications work are missing. And so when I say that, when we look at, for instance, the way serotonin is made, and how, we get it from our food, a lot of people just think it's tryptophan. Yes, but in order for us to break down tryptophan and turn it into 5-HTP to cross the blood-brain barrier, to do its effect, we need cofactors in the different steps. And those cofactors are your nutrients. So things like omega-3s, vitamin D, B12, B9, B6, zinc, those are all very important cofactors. Magnesium, very important cofactor. Molybdenum is a rare mineral, but also very important cofactor in this whole process. And so if you're missing nutrients, if you don't have a piece of that puzzle, it doesn't matter what medications we give you. You have a bucket with a lot of holes, and we're only plugging up one, maybe two holes with the medication, and you're never going to be full. Your bucket will never be full. So definitely consider those first and foremost, especially when you've tried a lot of different medications. And like I was saying, if you've landed on the Prozac being one that's helping you, you're at 40, and you're still having problems with the anxiety, you could add in buspirone. You could also max it out. Prozac gets maxed out at 60, so that could be something. But remember that you still want to do your due diligence and check for those cofactors, because it could help a little bit. But if you're missing those cofactors, it is not going to fill your bucket. So that's the whole point of that. And even in adding buspirone, so we could do all these things with conventional psychiatry to help a little bit, but you're always going to hit that point where they stop working. The other thing is with neuroadaptation in general with medications is that this is how treatment resistance is built, right? This is the pattern of treatment resistance. You get neuroadapted to one, it kind of stops working. So your brain gets sort of numbed out to even the effects of all this serotonin, all this norepinephrine, all these medications. And so it gets turned off to it, and you need more and more and more to get the same effect. And this becomes more like a physiological dependence. And then you switch, you basically go through the whole list of the antidepressants, then antipsychotics start getting thrown in the mix, or mood stabilizers get thrown in the mix. And then you start adding in all these other medications to help. And that's how you get polypharmacy and then treatment resistance. And then you end up getting ECT or TMS or these other, treatments. So before you go down that path, that's another reason why it's super important to check your nutrients, and then do so once you start replacing them and working with someone who understands how to replace them properly. Then you recheck and make sure you're replenishing them, and then always looking at your diet. What are you eating? How did you become depleted? Because if you're on the standard American diet, bingo, that's how you became depleted. If you're drinking lots of sodas, if you're drinking alcohol, you're depleting your nutrients, period. There's no way you're going to be absorbing your nutrients with a high soda or alcohol diet, along with the standard American diet. Very inflammatory. You're not going to be absorbing your nutrients properly. You're not getting your proper essential nutrients, or at least what you should be getting from your food, just because of all the inflammation from our poor diet these days. So clean up your diet, whole foods, get the inflammation out of the diet, drink plenty of water, make sure you're hydrated. Just going to the basics there would be great for you. And then leveraging medication after the fact. And then, of course, therapy, like I mentioned as well, to help with the thinking process of what's going on with the anxiety. What is the pattern of thinking, and how can we address that? All right. Sorry, I get on my soapbox so much. All right. Little sweet potato. Hello, good morning. I am a new Psych MP who often integrates psychotherapy into sessions. However, I also refer to individual psychotherapy with patients asking me what's the difference. Yeah, well, individual psychotherapy is definitely different than a psychiatric nurse practitioner integrating therapeutic approaches into their sessions. So it depends on the psychiatric nurse practitioner's training, what they can implement or what they can do. Like, for instance, with my training, we got trained in some CBT practices, and we did like group CBT sessions, and there was a program called COPE that we did, creating opportunities for personal empowerment. It was a CBT based program, and we got certified in that through our training. And then, as well as, we had to do therapy hours with our training. So yeah, you can incorporate some of those things, but it's mostly supportive therapy in session. And if you're limited to a 30-minute window, or that kind of a thing, the therapy that a psychiatric nurse practitioner can provide is also limited, because you're trying to manage the medication and get all that, and then trying to throw in a little bit of therapy here and there, which can become diluted or not as effective, right? So when you do individual psychotherapy and the psychiatric nurse practitioner refers out, which I do often, just because most of the people that are coming to me aren't coming to me for therapy. They're coming to me for medication management, holistic approaches, and doing all these other things, that there isn't time to do the therapy unless they want to do an hour or two or more session, right? To really do the work. So, and the other thing is the expertise. I don't have expertise in trauma. So depending on this psychiatric nurse practitioner's expertise, when she's going out and saying to this person, I'd like you to get individual psychotherapy, it's because she wants to leverage an expertise of a therapist. And so oftentimes I will do that as well, and say, look, you have a lot of trauma, in your life, and I think you really should do something like EMDR, and refer them to a therapist that is, highly trained in that. Or maybe somatic work, because I feel that that's showing up a lot in their body. So referring to them to a therapist that can do that. Or if they have maybe OCD, referring them to a therapist that functions or that does OCD specific therapies. There's therapies for insomnia. There's so many modalities of therapy that, as a psychiatric nurse practitioner, there's no way, we're going to be qualified in all of those therapies. And so we're limited to what we can offer in our sessions. So definitely, I think it's very good practice as a psychiatric nurse practitioner to refer out. So I'm glad that that's what you're doing, and just explain to your patients that the difference is that the person that you're referring them to is going to be more specialized, and they're going to be able to help them with whatever it is that that person's dealing with specifically. And also, they're going to have the time, more time to deal with them specifically there. Where if you're trying to do medication management and integrate the therapy, it's very difficult to do the two unless they're going to be paying for extended sessions, etc. So I think it's a good idea to refer to psychotherapy, for that streamlined therapy approach that's specific to the person. That's individual care. So that's good that you're doing that. All right. Moon Radiate. Hello. How do you manage lithium in patients with POTS? Yeah. So I answered this question actually in my newsletter. And so when you're looking at someone who has POTS, they have the postural, when position changes, their heart rate goes very, very high. And so when you're dealing with someone with lithium who's taking that, you just want to make sure that your sodium and fluid intake aren't drastically changed, and you're not creating an environment of dehydration, which can exacerbate those types of symptoms and lead to things like lithium toxicity. So that's the main thing there when you're dealing with someone who has POTS, and making sure that your diet doesn't change too drastically. And if you're living in a warm climate like Florida, especially right now, that you're being mindful of staying hydrated and not getting dehydrated. And then you're monitoring your vital signs, because those are going to be important factors. And then, of course, you should, if you're on, decent dose of lithium, that you're getting your blood work and making sure that you're not going into lithium toxicity, or those levels, those serum levels that could put you into lithium toxicity, which can exacerbate obviously the symptoms of POTS. So yeah, you're basically doing the same thing like you would do with anyone who takes lithium, but you're going to be a little more judicious about your nutritional intake of sodium and water, and just making sure there's a good balance there, because that can certainly throw things off with POTS. And obviously the lithium levels. So you just want to make sure that you're keeping a steady lithium level, but it's basically going to be the same as anyone. Even if you don't have POTS, you have to always make sure that you're monitoring those things, because you could easily go into lithium toxicity with dehydration and too much salt, not enough water in your diet. All right, Nurbama. Hey, Nurbama, thank you for the super chat. You're on Effexor 187.5 and Buspirone 15. Decided to go to the gene site. Decided to do the gene test to see what medication I can metabolize best. What are your thoughts on the test? Yeah, so there are two tests. There's there's more than two tests, but the two popular ones, GeneSight and Genomind, and I love both of them. Genomind, you do tend to get a bit more information from that, and it's a very information heavy, but still, very clear on what medications you're metabolizing, what medications you're not metabolizing. And I think it's great, especially for someone who has tried a lot of different medications, and perhaps there could be something genetically going on there that you're not metabolizing properly certain medications. Commonly, we see the CYP2D6 as a someone who's a poor metabolizer of that. Don't do well with certain antidepressants, and there's a lot of antidepressants that use that pathway. So you have to be careful there. But it'll be good to help guide you into understanding what medications you can metabolize normally, and which medications you could potentially be having trouble metabolizing, and could either be not effective because you're rapidly metabolizing them, or maybe cause side effects because you're slowly metabolizing them. The other thing is that it's also looking at certain markers for serotonin reuptake itself, and serotonin transport genes, to see if serotonin, like the SSRIs, if you would be sensitive to them, maybe have side effects of SSRIs, and maybe going the serotonin route wouldn't be right for you. And also, there's a couple histamine genes on histamine which show like maybe you would be more sensitive or have a reaction to those medications like say lamotrigine or modafinil that have the Stevens-Johnson's reaction as a potential reaction. It'll let you know that as well. So yeah, both of those tests, and they also do Genomind will automatically do the MTHFR. With GeneSight, it's an add-on that you have to add. The clinician will have to add it on to the test. So make sure if you do the GeneSight that you get that MTHFR added in. The Genomind is going to look at the MTHFR, the CT and the AC variant. So it's going to look at two separate genes for MTHFR, which I think is great as well, which is why I do lean on, that one tends to be my favorite. And then it also looks at other markers like BDNF and whether or not you would be someone who could utilize exercise as a treatment, and really get good benefits from that based off of your different BDNF genes. And then it looks at some others too, the VALMET, the COMT, and those types of genes as well. And it gives you some information on that, on how you're able to metabolize dopamine and those types of things and leverage that. So it could give you some information from the Genomind. They actually will also include like supplement recommendations and things of that nature. And you can put all your medications and supplements in there and it'll tell you which ones based off your genetics work well for you and which ones wouldn't work well for you. So that's why I like that one better. But either one's going to give you a lot of information. But like I always say, as far as the whole holistic approach that I like to do is make sure that you're also doing your labs, and making sure all of your nutrients, are where they're supposed to be and optimal, so that whatever medication you do decide to switch to or start based off of your gene test, that you're providing it with a good, substantive starting point with the nutrients. So make sure not to dismiss that as a thing as well, because even though things will be in the green on the GeneSight or the Genomind test saying yes, these you metabolize, it doesn't mean they're going to work. So that's one thing that a lot of patients will misconstrue or think that, hey, oh, it's in the green, so it's got to work. It certainly may, but it's just saying that it's green, you'll metabolize this well, and you're going to have very low risk for the side effects of the medication because you're metabolizing it properly. So that's basically what it's showing, but it's not showing your nutrient deficiencies and all those other things that we need to consider in the whole picture. So always make sure that you're doing that as well. Okay. Rosenquist. Why does magnesium, B6, and vitamin D supplements make me depressed and give me low mood? I have to stop take them. I even take them with cofactors. I take venlafaxine. Yeah, not sure. You may be taking too much and not sure if these are things that you need. That's why it's important to do an individual approach. So why did you start taking these to begin with? Just because you heard they were cofactors and you just decided to take them doesn't necessarily mean that they're going to give you an abundance of an effect. And also the types that you're taking is another factor. Are they crossing the blood-brain barrier? That's another thing to consider. Is your magnesium a glycinate or an L-threonate? B6, you can take either form, P5P or pyridoxine HCl. Vitamin D, is it vitamin D3? Are you pairing it with K2? Are you taking it with food? Those are things to consider. And then, like I said, making sure that we're not doing too much here as well, because there is a thing as toxicity in doing too much vitamins. So did you get your labs and are you dialed into optimal? Those are the other questions here where, they may be making you feel depressed. So I would look into that as, as an issue. And whether or not, with the venlafaxine, how you're taking it. If you're taking venlafaxine in the morning, are you then taking your nutrients in the evening? and those kinds of things to think about as well. So a lot of factors there. Definitely do your blood work. Make sure that you're optimizing your nutrients, not, because there is a good optimal level and there is such a thing as too much of something. So you always want to make sure that you're staying within those optimal ranges and not going into too much, because that can also create problems. And then also when you're looking at cofactors, that's one thing, but also medical conditions. We don't want to ignore that. We don't want to ignore thyroidism, hypothyroidism, hyperthyroidism, Hashimoto's, or autoimmune conditions and things of that nature, that even when you replete nutrients, though nutrients are one big factor, that something else could be going on, and oftentimes is. Um, iron overload, those kinds of things can be issues as well. So yeah, making sure you're looking at the whole picture, not just a couple of cofactors, that because you read that this was good or something like that and you just decided to take it. You want to make sure that when you're taking supplements, you're doing it with a purpose, and that it's individual to you and your needs, your biological needs, not just blindly taking supplements, because you won't get the same effects. Okay, hello. 14142. I had zero energy and feeling tired all day. Went to the psychiatrist a couple months ago, and now I have a little bit more energy. Well, that's good. On vortioxetine and alprazolam, by the way. Okay, yeah. Vortioxetine, multimodal antidepressant, so it can, help with improving energy. Alprazolam, on the other hand, is an anxiolytic medication, should be taken as needed and sparingly. But I'm glad to hear that you're doing well after seeing your psychiatrist. Moon Radiate, hello. Do you know any good psychotherapy certification courses? Well, the Beck Institute has one on CBT specifically. That's a very good one. And the EMDR certification, if you want to go into EMDR, EMDRIA is the certification body. That's another good psychotherapy certification course to do. And Peter Levine's somatic therapy training is another good one, if you're looking at helping people with trauma and getting into somatic therapy work. Those are the three that I would say would be really good ones if you want to get certified in specific psychotherapy modalities. Those would be the three that I'd recommend. ABBA for life. What is your experience with quetiapine on treating anxiety and depression, and what magnesium is best? Okay, so quetiapine on treating anxiety and depression, my experience with that is with patients that it can be very effective. The downside to it is that it can have side effects. And particularly when I have patients on Seroquel, especially high doses, I want to monitor their labs and look at metabolic syndrome and making sure that we're not heading into that direction. But not every patient has that. And I have some patients that do really, really well on quetiapine, and they eat the right foods, they exercise, they stay in shape, and they're not heading or trending that way, which is great because they found something that's working well for them. And so yes, quetiapine can be very, very helpful for treating anxiety and depression. And I have a video on Seroquel and how it's a very versatile antipsychotic because of that fact, period. When it comes to magnesium, or maybe, did you mean magnesium or milligrams? Maybe you meant milligrams. I'm sorry. When I see mg, I think magnesium, but I think you meant milligrams with quetiapine. So from treating anxiety, you could do like the low dosages, 25, 50 milligrams, and you can even do that as needed for patients. And that can be very helpful. When it comes to depression, though, you tend to need the extended release, higher doses, 150, 300 milligrams for a person with depression. So, and you can adjunct it with an antidepressant as well. But again, making sure that you're being mindful of, metabolic syndrome is a factor. Weight gain can be a factor in monitoring that with your provider. But yeah, for anxiety, really the smaller dosages are going to be better because it has a more calming effect with that. You can go a little higher if you need to, but if I'm trying to treat just, a little bit of anxiety, especially anxiety at night, I find that I don't need those high dosages with it, unless they're missing cofactors and those types of things, which I always, like I've been mentioning, making sure that we're checking those nutrient deficiencies and rolling them out and supporting the person nutritionally. All right, Abu Bakar Khan, hello. I have to take antipsychotic along with anti-Parkinson's. Is still mine involuntary upward eye movement. Either my doctor doesn't understand. Why is there no solution? Yeah, I'm not sure here. The thing with antipsychotics is when you have Parkinson's and then you're taking the Parkinson's medications, um, they're doing the opposite thing. So, I'm not sure if you're just trying to target the involuntary upward eye movement, because that could also be a side effect of the antipsychotic. So, make sure that you talk to your provider about that, especially when with the Parkinson's, talk to your neurologist about this. They're going to be more dialed into this than your psychiatrist or psychiatric provider. But certainly, um, these two medications are doing the opposite of each other, though I have seen them use, especially with like a Lewy bodies presentation, we'll use a little bit of an antipsychotic to help with that type of agitation that's going on in Lewy bodies, which is like a Parkinson's type of dementia. Um, so I can see, providers, we do utilize antipsychotics, and usually in very small dosages, to help patients who have anxiety or agitation, who also have Parkinson's. But it is a little bit of a dance that you have to do there, because one is a dopamine agonist, the other one is a blocker. So you are doing, so you gotta, with timing is a factor. So the timing that you're taking the antipsychotic and the anti-Parkinson medication, you can kind of play around with that and, with your provider. But talk to a neurologist. They're going to be the ones more dialed in than your psychiatric provider on helping to manage both of these medications well, and to do it properly, because it's certainly not my wheelhouse. I don't treat patients with Parkinson's. So, definitely talking to an expert in that, which would be a neurologist, would be what I would recommend you do. All right. Noah. Hello, Noah Lepin. What is the maximum dosage of gabapentin you suggest? What is the best antidepressant to take with clozapine? So gabapentin, you can go as high, 2,400 milligrams, of course, dividing doses. So that would be like 800 milligrams 3 times a day. Would I suggest that? No. And I don't like to use gabapentin, to be honest with you, because I mentioned earlier about like Lyrica is a gabapentinoid, it's pregabalin, and how they act on the benzoreceptors very similarly to the benzodiazepines. So long-term can have issues with trying to get off of them. If you ever reach that point of tolerance, and it's not working anymore, etc. So I wouldn't want to max it out. If I were using gabapentin, it's not something that I like to use at all, unless someone's already on it and they're doing well. Then we'll keep it going with the understanding that that there are these risks with gabapentin. So yeah, I mean, if the person needs to go as high as 2,400, yeah, but in my practice, I would say the few patients I have on gabapentin, maybe their max dose is like 1,200, 600, something like that. They're not very high. And then the best antidepressant to take with clozapine. So clozapine or Clozaril is antipsychotic. With antidepressants, with that one, I don't have patients on Clozaril. It requires REMS, to do, to enter into the REMS, which is like this program where you have to monitor your patients and submit all the information because of the agranulocytosis that can occur. So I don't have patients on it. So I don't really can really say what's the best antidepressant. And really, there is no best antidepressant to take with this medication or that one. It's what works for the person. And that's what I try to drive home with the videos is that there isn't really like, this is the best antidepressant ever. It's really going to be like, yeah, this antidepressant has a lot of efficacy and clinical research that shows it works and it helps a lot of people, but doesn't mean that it's going to be the one for you specifically. So that clinical picture is going to look different. And like, Nerdbama was saying, with it getting a gene test too, that's going to give you a whole other that's another factor to throw in. So whether or not, you're going to respond to a certain antidepressant would depend on whether you can metabolize it properly and whether you have the proper nutrients and cofactors to support the neurotransmission and what you're doing to the brain when you add in psychotropic medications like antidepressants. So it would be up to, talking with your provider, figuring out your symptoms as well, and then also making sure to do your labs and rule out other things before deciding on adding in more medication, because it's a trend then basically to treatment resistance when we start adding in a bunch of medications. Okay, Patty Legassi. Hi, I have health anxiety that's very bad. I've tried all antidepressants and had gene site testing. Just recently tried Zoloft and I felt awful. I was only able to take it for 5 days. Yeah, the health anxiety is definitely one where you definitely need to be in therapy. A lot of this has to do with your thinking, and the power of the mind. I cannot underscore the power of the mind. Alicia Crum has done a lot of work through, I believe she was in Stanford University, but a lot of work on the power of the mind in different studies. And she had an interview that she did with Dr. Huberman. If you know who he is, he does podcasts and talks a lot about different things dealing with neurology and whatnot. But his interview with Alicia Crum was really good on the power of the mind. And when it comes to health anxiety and anxiety disorders, really you need to be in therapy to work on what is your thinking process behind everything that you are trying to take to help yourself. Because everything's heightened, everything's exaggerated with a person with health anxiety. You take something and then all of a sudden you start feeling, maybe get a little twitch or spasm. You think it's the medication right off the bat, or you start hyper focusing on every little symptom that you have and wanting to get answers, etc. When in fact, that may not be the case at all. And so it's really about how you're dealing with it, with how you perceive the medications as well. Because in her research, she found that people who perceive things as bad for them, their body biologically will react like it's bad for them. People who perceive things that, like, yes, this is good for me, actually their body will biologically respond like it's good for them. And from what I recall, there was the study that sticks out in my mind was dealing with like milkshakes, and they gave each group, the same high calorie, high in fat milkshake, but they told one group that it was good for you, and they told that group that it was actually a healthy shake. They told the other group, that it was what it was, a very bad milkshake. It's very bad for you. And then they checked the blood work in these participants that took these milkshakes for, I forget how long. And the people that believed that it was a good milkshake and it was good for their health actually had better biomarkers than the ones that knew that it was a bad milkshake and bad for them. So not saying that you can go and just start drinking all these bad milkshakes and say to yourself, this is good for me, but just showing the power of the mind and how the power of the mind affects how your body biologically responds to things. So fixing the thinking process here with something like health anxiety is always number one. When I have a patient with health anxiety, I always highly encourage and recommend good, therapy, and CBT therapy would be good to really work with someone who can help with the thought processes and what you're going through and how you're thinking things through with every aspect, including your medications. All right. John MV Freedom question. I'm on 75 milligrams of venlafaxine for 2 to 3 years for anxiety. Okay. Get blurry vision. Late in the days, whether on 37.5 or 75, I take it at night. Unfortunately, blurred vision is a side effect. And you're taking it at night. Yeah, so that's why. Okay. So yeah, you need to talk this over with your provider, because blurry vision is a side effect of venlafaxine. I'm surprised you're taking it at night, because it can have, and commonly does have, insomnia as a side effect. So most people take venlafaxine during the day, but then I imagine you may then have blurry vision during the day, or problems when you're trying to work or whatnot. So, but yeah, that's definitely a side effect. Obviously not a favorable one. If it's impacting your health, get that checked. Now, the other thing with blurry vision that I want to mention that just came to mind is that it could also be ocular pressure. Increasing intraocular pressure can cause blurry vision. So don't dismiss that. Get an eye exam, because that could also be a factor here. And venlafaxine can increase intraocular pressure, which is one of the mechanisms of how it can cause that. So definitely get that checked as well, to make sure it's not increasing your intraocular pressure, or that maybe you have something else going on there. Okay, hello. Taking 0.5 milligrams of alprazolam a day. Do you think it can be harmful effects long term? Yes, I do. And the reason I do is because there are tons of studies out there now, and several new ones that I mentioned in my video on benzo-induced neurological dysfunction, that talk about these harmful effects of using alprazolam. Even if you're taking a small dose, there's this whole misconception that just because I'm taking a little dose of XYZ benzodiazepine that I'm going to be fine, and that's not true. Unfortunately, Dr. Christy Huff had passed away just a few months ago, and she was the medical director of the Benzo Information Coalition. And she had problems with this, with only alprazolam 0.25, and she was only taking it as needed for very short term, and developed this benzo-induced neurological dysfunction. So, yeah, so yes, it can have harmful effects long term. Now, not 100% of people have long-term health effects. So this is something that you have to weigh out. This is something that you have to consider. So I don't want to be all dogmatic and go like nobody needs to be on a benzodiazepine, because you get a lot of people that they love their benzodiazepine, and you better not take it away from them, because it works for them. So you need to be an informed patient. You need to be informed and know that these are the risks that you're taking, so that if, God forbid, you end up having a benzo-induced neurological dysfunction state, you took that medication knowing that this could be a risk later on down the road. So you can't, say I never knew, or I was blindsided, because you hear all these horror stories where patients say, I never knew it was going to be harmful, but it really helped my anxiety, so I took it, and then 10 years later it just hit me, and now I'm going through torture, and now, and you hear horror story after horror story. And the Taper Clinic, Dr. Joseph Witt-Doring, does a really good job of interviewing these people and getting their stories, so that you can see the horror of these medications, like benzodiazepines, but even other psychotropic medications have their long-term harms as well. It's not just the benzos. So really, anytime you take a psychotropic medication, you're taking a risk. So if you want to be made well aware of all the risk, I would advise going to benzoreform.org. It is the Alliance for Benzodiazepine Best Practices website, and they have tons of information on there, including they have their informed consent. Their patient informed consent is a very good tool to look at that was developed by the Alliance along with the Benzo Information Coalition Group and other people in that field, other leaders and organizations in that field, created the proper informed consent for benzodiazepine. So I would look that over. And then, if you're not already in therapy, get in therapy. Therapy is first line treatment, again, for anxiety disorders. I keep mentioning that because it's important that you don't dismiss the power of the mind and things, how changing the way you think of things can really improve your health, and improve your anxiety, and that you don't lean so much on the Xanax or benzodiazepine medications. That's ultimately the goal. When these medications came out, they were supposed to be short term only, and people just started using them all the time because they're easy. You take a pill, your anxiety goes away. But I want to, give everybody like a flash, hey, alert, alert. We all are supposed to have anxiety. Anxiety is a part of our nature. You're never going to get rid of it. So instead of trying to get rid of your anxiety, learn how to deal with your anxiety, because anxiety is a part of life. We're never going to get rid of it. So learn how to do things like vagus nerve massage. I talk about that. Marlo, if you want to put that link of the vagus nerve in the video, how I talk about, how important vagus nerve is, for us, how to utilize it to decrease your your sympathetic tone and increase parasympathetic tone. If you're living in sympathetic fight or flight all the time, definitely a good tool to utilize. But yeah, learn some ways to manage your anxiety instead of taking the pill, because it might be the easy way now, but down the road, 10 years from now, you're going to find it's actually the hardest road, unfortunately. Jesus Christ loves us. Amen. Yes, I love that. What is this for quetiapine fumarate? Fumarate. Quetiapine comes in different generic formulations of Seroquel. So it's just one of those that it's bound to. It's just like the generic name for Seroquel or quetiapine. Little sweet potato. If prescribing a benzo, which is your go-to and what dosage and for how long? So yeah, if I prescribe a benzo, I usually end up doing something like a diazepam, because it's longer acting, less risk of a person taking it or needing it every single day. And I'll do 10 milligrams, give them 2 weeks. And, that's pretty much it. If they're on a benzo already, and they're hell bent on staying on that benzodiazepine, then I say, okay, I give them that informed consent. So you can also go to benzoreform.org and get the informed consent on there. I think it's under resources, for prescribers and patients. I think it's listed under each of those sections. But print that out, have it in your office, and you give that to patients and they sign it, because then they can't blame you. Because that's typically what happens is, if you give them a benzo, whichever one that they're asking for, and and it works for them, that's great. But then they're on it long term, and then a couple years from now, then they're going to be saying you gave them a benzo and you didn't tell them that it would cause this injury. So you always want to make sure that you preface it with that. But I definitely stay away from prescribing the benzodiazepines. If I feel like they do need it, I'll use the diazepam. It's longer acting, less risk that they're going to need it or take it every day, and really good to help with insomnia and anxiety. So just once a day, they could take it at night, and it'll help that throughout the day, and only give them 2 weeks worth, 14 pills. That's it. If there's someone who's traveling, okay, that's another thing. I would do like a shorter acting, like something like lorazepam, and do like a 0.5 milligram of lorazepam, and only give them, depending on, like they're traveling and then like they're doing a round trip or whatever, and so I'll only give them like 3 or 4 tablets, or depending on how long they're going to be traveling for, or etc. But only give them enough to help them through, that period. So you're not giving them a 30-day subscription. You're only giving them a couple of pills, to help them through something like that. So yeah, something like lorazepam, and with lorazepam, I also consider. So I would choose that over diazepam, especially if someone has a history of liver impairment, because lorazepam is going to be less toxic and to the liver versus diazepam. It's a little heavier liver metabolism, and is going to, for someone who has issues with their liver, wouldn't be one that you would go to. So those are things to consider as well when you're looking at prescribing a benzodiazepine. Is what do their liver enzymes look like, and then short-term use only, specifying that, really drilling it down. If they push back on you and you feel like, okay, you want to help them, or they're already on something, like a clonazepam, and I try to stay away from those two, clonazepam and Xanax, starting someone on either of those, because those are the worst to come off of. So I definitely avoid starting someone on those. But if someone's already on those two and they're, like I said, really like, this is what I need to be on, then I whip out that informed consent. I have them initial, and I sit there with them, make sure they're reading every single line, and that they know what they're signing up for. So that's all you can do at that point. Or you can be a provider who doesn't prescribe controlled substances. There's some providers who do that too. All right, Lulu Love. Hey, good morning. Why don't mainstream docs and even integrative docs not looking all the valuable information in cellular blood work? I presented yours, which is so detailed, and it did not look at it. Yeah. I don't know the answer to this, and this is very unfortunate. How there's providers who maybe they don't have the time, or maybe they don't understand how to read that type of information, because it is very detailed and it takes a lot of time and skill to read it all and see those patterns. And so some providers are, they have an ego. Okay. And if a patient comes to them knowing more than what they know, a lot of times providers will shut down. So, and it's also like the way you present it to them, et cetera. If you're coming in very aggressive, they may just shut down altogether and not even want to look at it, because they have their own process. So you have to respect their process of how they do things and how they look at things. And then you can say, and by the way, if they're talking about, oh, you have these symptoms, you mentioned your symptoms to them, and they start explaining how they would go about, looking into it a little more with their labs, et cetera. Then you can say, oh, I have done some labs recently. If you want to see them, I have them available. Then you can, either pull it out of your folder or send it to them. At that point, they might be more receptive. But it's hard to predict what's going on in their mind. But the one thing I do know with providers, especially doctors, because I deal with, as a psychiatric nurse practitioner, we're considered mid-level practitioners, even though, we do get a lot of training and a lot of knowledge, especially very heavy in medication. Our studies very heavy in psychopharmacology, because that's basically what you're doing. But, when I get patients who consult with me and I write up a very nice, recommendation that they can take to their provider, a lot of providers are not receptive to that because of their ego. And how is this nurse practitioner going to tell me what to do? When I'm just saying, like, based off of, and I give them all the information and all of the details and all of these things. And that provider still is like, they don't care. They're going to do whatever they want to do. And sometimes I feel like they may even do something completely opposite of what you're recommending, just because to prove a point. And that is unfortunate. And so I can't say why, except the fact that they may have, big ego, and they feel that their way is the way, and they're just closed off, and they're not very open-minded to other ways. And then the other side of it is how you present it to them. You don't ever want to, with a provider, put them on the defensive end. You always want to, like you're trying to be helpful and giving them a little more information as the patient. Like, well, I appreciate and I respect that you want to do these labs, and I want to do them, but I also had labs done this day and time, if you want to look those over so we can compare the two, to kind of get them open and looking at it, instead of just saying, I had all these things done, look them over, what's wrong with me? Not saying that you do that, but it's just the way that you approach the person too. And if you're doing all those things right, and they're still kind of disregarding the information that you're bringing to them, then you got to go move on to a different provider, unfortunately. And from what I'm hearing, it's becoming more and more difficult to find providers that have the time to sit with you and go through all of the information that's required to really help someone in this type of holistic manner. And it is unfortunate. It's unfortunate for providers like myself, who I'm only limited to psychiatry, right? So when I find things, I want to make sure the person's going to the appropriate people. And it's really hard to get providers on board with helping patients fix, these underlying things that are wrong with them. So yeah, it's a struggle. I'm hoping that with the new generation coming in, it sounds like a lot of providers are going more towards a functional approach. Maybe it's just because I'm in that world, but I'm seeing a lot of doctors that are switching and turning from conventional medicine to go into more of a holistic, to have more time with their patients, to be able to take the time to do these things. So hopefully it continues to change. All right. My walkies, hello. Good to see you today. Good to see you too. I am getting angry side effects with Wellbutrin. That's a side effect, yeah. Kindly suggest the medication on that side effect without lowering dose. I'm on 150 milligrams of Wellbutrin. Well, this is from the norepinephrine and dopamine stimulation from Wellbutrin. It can cause agitation, anxiety, restlessness, and those types of things. You could, if we're looking at conventional medicine, now here we go with adding medication. This isn't what I like to do at all. But if it's to kind of mitigate or lessen this state, because you're feeling really good on the Wellbutrin 150 and you don't want to lower it because, maybe your depression is really good, but now you're just feeling a little agitated. You could add in a couple different medications can help. So clonidine is one, 0.1 milligrams that you could do once or twice a day. So depending on your blood pressure. So, obviously talking this over with your provider, that's one that you could utilize. Buspirone is another one that you could utilize to help, with this angry kind of side effect, agitation, and kind of helping to decrease that a little bit. So you're going to be looking for things that kind of, to help to treat anxiety. That's where a lot of fear, anger, those types of emotions and things are coming from. And it's really that norepinephrine in that. So you want to try to, get that down. Now, when you're adding in these different medications, you then have to worry about those side effects. So that's something to consider as well. But those would be my go-tos. Clonidine first. That tends to be, more tolerated than adding in buspirone. And just a small dose, 0.1 milligrams, should do it, but you may need it twice a day. But just make sure your blood pressure is okay and it's not too low, because it can lower the blood pressure. But always look over the side effects of when you're adding in other medications, to help side effects of another medication. And then also look at nutraceuticals too. Sometimes things like inositol can be really good for helping irritability, or even like magnesium glycinate can be very helpful, for someone, to help. So you don't have to go with pharmaceuticals. You could try what we call nutraceuticals, and use supplements to also help, and they would be safer. And that could help. So starting with something like magnesium glycinate, 200 milligrams twice a day could really help, um, with that HPA access, getting that norepinephrine down a little bit to help with ease, the agitation. And that's where I would go versus trying to add another medication, which is what conventional practitioners would do. I would be looking at things like magnesium glycinate, maybe, inositol can also be very helpful, and even maybe L-theanine. But I would start with magnesium, 200 milligrams twice a day, and see how that works. And then if you need a little bit more of anything else, utilize those things. But also looking at your blood work, making sure that you're not nutrient deficient too. And maybe that's why norepinephrine seems to be dominating in this clinical picture. So yeah, I would be looking at your labs and correcting those things. And then you could add in magnesium. It's hard to be toxic with magnesium. You could, for most people, safely add magnesium in as long as they don't have renal failure, and go from there while I'm looking at labs. But yeah, there's conventional way and there's nutraceutical, holistic practitioner kind of ways to do it. But certainly you can if you're getting benefit from the Wellbutrin. Mara S, hello. Devalparex, 500 milligrams, delayed release. So Depakote at 2 for 1,000 milligrams at bedtime. Okay, so 1,000 Depakote bedtime. And then Depakote 250, delayed release tablets, 750 in the morning. Quetiapine 100 milligrams at bedtime, and benzodiazepine 1 milligram tablet. Okay. I've been on these medications, including Klonopin, 1 milligram. Okay. For bipolar type 1. And I've been with most of these same medications since 13. I can notice that my bipolar type 1 with PTSD with delayed expression, I actually got placed cold turkey by a psychiatrist. Okay. I was not given a chance to ask why I was not allowed to lower my dose of Klonopin by the unprofessional psychiatric medication doctor. Okay. Cold turkey by a new psychiatrist for my Klonopin, and was not even slowly taking off safely, which I had withdrawals. Yeah. Is there a question? Is it safe for any medications, especially Klonopin, for them to cold turkey and then won't care because I have horrible withdrawals? No, it's not safe to come off of, especially clonazepam, any psychotropic medications. You shouldn't come off abruptly cold turkey. They're switching, so you can switch from one to another, safely. There's transition. So depending on how long you've been on a medication, how long the transition goes, some medications you can just stop one and start another, especially if you haven't been on one for long term, or if the other medication is very similar, like going from one SNRI to another SNRI or something like that. One multimodal antidepressant to another. I mean, there's certain things that you can take one away and add another one safely. And then there's also switching schedules where you would want to kind of taper in one slowly, etc. But if you're going to completely come off of a medication, you definitely want to do it slowly. So if you're going to come off of clonazepam, especially 1 milligram you've been on for many years, it's very, very unsafe to come off cold turkey. Only reason someone would want to come off of this cold turkey is if maybe you were drinking alcohol with it and you developed some kind of alcoholism along with it, and they were trying to manage the alcoholism and with something else, like in a rehab setting, they may switch you to something else to taper off of that to help with the detox process. And then, but even then you're tapering off of something. So yeah, you're going to have horrible withdrawals, just cutting you off of clonazepam. And I'm sorry that you're going through that. The only way to really mitigate this is by a slow taper. Once you've been ripped off of it and now you're going through withdrawals, it's unfortunate you might end up in a protracted withdrawal state where the withdrawals become long term. And that can create like that benzo-induced neurological dysfunction that I mentioned in the video on that. And at that point, you really want to focus on calming the nervous system down. Fortunately, you're on good amounts of Depakote, so you're protecting yourself from seizures. So that's good, because that's the other thing that you worry about with ripping off a benzo so quickly is the danger of the seizures that could occur. High doses of Depakote like that could actually be protective in that regards. But yeah, you have to work on, in this state, there's not a lot that can help you medication wise or even supplement wise, because a lot of things you might end up being sensitive to after you are ripped off of a benzo too quickly and are in a protracted withdrawal or withdrawal state period. So a lot of the things you have to do are going to be a lot of the vagus nerve work, the deep breathing, that kind of thing to help calm the nervous system down. That's really what you want to focus on. Most patients can tolerate magnesium glycinate very well. There's a very small subset that will just react to everything, but most patients can tolerate magnesium glycinate. That can be very calming on the nervous system. And with withdrawals, you want to do higher dosages, so like 400 twice a day. Omega-3s are also very protective, and most patients can tolerate high doses of omega-3s. And when I say high doses of omega-3s, I'm talking 2 to 3 grams total. So that's 2,000 to 3,000 milligrams total a day that you're going to want to take of omega-3s, and make sure that they have a high concentration of EPA and DHA, because that's what's going to help with the brain health side of things and help calm things. So EPA high and EPA higher than DHA in this circumstance, if you want to use some nutraceuticals to kind of help. And then other things that people will use that are iffy, like most people, omega-3s, magnesium, pretty much across the board, very helpful. Not a lot of people. But when it comes to other things like L-theanine and GABA, like now you're risking like 50-50 on whether or not you'd react to those kinds of things. So I would stay away from those at this point and just work on calming the nervous system down with vagus nerve exercises, deep breathing, and then see if you can utilize and tolerate some magnesium or omega-3s. Patty Lagasse, hello. What type of provider do I look for? I have health anxiety and can't meds. Also have, oh, you have MTHFR. Well, that makes a difference. And hypothyroidism. So make sure your hypothyroidism is, because sometimes with that treatment, make sure you've gotten that recently checked with your endo, that you're not going into hyper, because sometimes that can trigger anxiety if you're on a dose of Synthroid that maybe a little too high. I've had a patient that she had Hashimoto's thyroiditis and was presenting with hypothyroid, symptoms, and it popped up positive, etc. And when they were titrating her Synthroid, she right away had a serious anxiety reaction. So then when they lowered it, of course, it got better. MTHFR, a whole other factor. So make sure that your homocysteine is being checked. With your B vitamins, B12 and B9, of course, with MTHFR, that's your folate. MTR and MTRR are the other B vitamins. So MTHFR is particular to folate, not B12, but you still want to check your other nutrients, B12 and folate together, especially when homocysteine is high. Okay. And make sure that's getting under control, and the type of provider that you look for with health anxiety. So you want to have someone who understands like integrative medication and understands like a holistic. So a functional integrative practitioner can help you with the medication side and integrating nutrients to support the MTHFR and even help support your thyroid. With things like selenium and zinc and those kinds of minerals that can help that aspect of things. So if you go on Psychiatry Redefined, they have a resources tab. So psychiatryredefined.org. it is the website that Dr. Greenblatt has on. He has one on lithium orotate that I always refer patients to when we're talking about lithium orotate and how you can use it in so many different ways. But his website has a tab that has resources and then providers. So that list of providers actually have gone through his training, which is the fellowship program that I've just done a year with. I'm going to do another year with him as well in that, because it's so good. It's so much information. So providers that have gone through a training like that would really be dialed in on how to treat someone who has, like, especially MTHFR and health anxiety and those types of things, using nutrition and nutraceuticals and those types of supplements. When you're looking at a therapist, okay, you want to look, because remember, like I told you before, you don't want to ignore the therapy component and the power of the mind. So working with someone who can do CBT and acceptance and commitment therapy, I think that combination is really good for health anxiety, because you have to learn to sit with the feelings and like learn how to deal with, using skills, your nervous system and calming it down and those types of things, but also understand what it feels like in your body and what else could be triggering it and those kinds of things. Not only thought processes, but maybe certain people, places, things, and those kinds of issues. Those can all be done in therapy work, working with someone who's good in both ACT and CBT, and combining those two together would be really, really helpful in treating this in that kind of way. So I would, if I were you with health anxiety, wouldn't even want medication. So I understand. I would find a therapist specific to CBT, ACT therapy, and then I would find a practitioner on Dr. Greenblatt's page, an integrative, functional psychiatric practitioner, and find, you could go. I don't think he has them. He does not have them right now, like separated state by state. I wish he would, but you could do like Control F and type in your state, whatever your state is, and then see the practitioners that pop up like that in the search, and then call them and ask them, find those practitioners that will specifically be able to help you in that regards. Okay. Linda Sims, hi. I was on Zoloft with Abilify as add-on for depression and anxiety. Abilify worked so well that I stopped Zoloft because it wasn't doing anything, but the Abilify is working on its own for me. Do you know why? Yeah. So Abilify can, it's a partial agonist at both serotonin and dopamine. So it helps to modulate those two. That's like its primary function. It has other targets. Those are the primary ones. And so someone with depression and anxiety, it's probably doing a really good job of the partial agonism. And that's pretty much maybe all you need. And maybe the Zoloft was too much with the serotonin, where the Abilify is helping to modulate both serotonin and dopamine very well, that it's able to treat your depression and anxiety. I hear that a lot with Abilify and even Vraylar and Latuda with patients, that they find that it's really just that one that's helping them. And you know what? If that's what's helping you, great. And guess what? It's minimizing your medication burden. So I don't think there's anything wrong with it. And it sounds like you probably didn't need so much with the Zoloft, and even that could have created a state of neuroadaptation and like blunting in the end as well. And that tends to be what happens with treatment resistance. When you add, gosh, the person becomes emotionally numb. They're like a zombie at that point. It's like a chemical lobotomy. And then we call them treatment resistant, and then we want to start doing all these other things to them, and it's unfortunate. But yeah, it's good that you kind of figured this out on your own, that Abilify is working well on its own, helping your depression and anxiety. And I hope that you've been kind of listening and gathering more information, because even though it's helping and that's great, I don't want to discount that. I also think it's good that you would do your labs and ask your providers to look at your nutrients, and just make sure that you're supported that way so that it continues to be something that's helpful for you long term. So look at your nutrients, for nutrient deficiencies, look at those basic labs for mental health that I talk about. And also doing exercise. Gosh, I haven't mentioned exercise yet today, but I usually go on that tangent too. But how exercise is also good for you. So even just walking, light exercise doesn't have to be very rigorous or anything, but doing a couple, 3-4 times a week, walking around the block, 20 minutes, that kind of a thing can be very helpful for building up circulation and helping also to improve your mental health. So just keeping things like that, lifestyle factors in place, so that this could be something that long-term can be something that you use. They say Abilify isn't supposed to work on its own, but for me, it's all I need. Yeah, it can work on its own. I don't know what they say. They, yeah, who's they? No, it can absolutely work on its own, and is actually used for patients who have bipolar, depression or mania, and for bipolar as a single agent. So yeah, it could also help someone with depression and anxiety. Mm-hmm. Hi, Bush Baby. I'm currently tapering off a number of my medications. How is it best to taper off Wellbutrin? I am on 150 milligrams every morning. So, Wellbutrin isn't a medication that typically has a withdrawal type of, not very commonly. Like I think I had one patient who said, but I think she's dealing with health anxiety as well as, I think there was something in her gene site or something in the genes that bupropion was causing a lot of side effects. So I think she was dealing with more with that aspect of it. So, but if you want to just be on the safe side with tapering off of Wellbutrin, the lowest dose that you can get is going to be 700 or 75 milligrams. So jump from 150 and then you can get 100 milligram tablet. So you could do that. And then from 100 to 75, is what I would do if, just to do my due diligence there. But yeah, it's good. I'm hoping that as you're tapering off too, that you're starting to feel better. If you were on quite a bit of medications, and Wellbutrin is actually a good one to start with, just because it's like a safer one to come off of. And a lot of people can come off of Wellbutrin without any problems at all. So it's always a good one to start with. Darrow Houston, hi doctor. Can I take Lyrica for anxiety? What is the best options? Thanks. I'm a psychiatric nurse practitioner, so I just want to make sure I'm never posing as a doctor or someone tries to accuse me of that, because I always make sure it's clear. I'm a psychiatric nurse practitioner. Okay, but when it comes to Lyrica for anxiety, I mentioned it very early on when someone was talking about their combination of meds and like Lyrica was thrown in there. It's actually a gabapentinoid, so it is going to, unfortunately, work on those GABA receptors very similarly to the benzodiazepines. Now, yes, that can be effective for anxiety. However, same problems with long-term use and causing tolerance, dependence, and all of those other things. And then benzo-induced neurological dysfunction, which you probably don't want. Not to say that that happens for everyone, but it happens for a good, 20% of people or so that end up, in benzo-induced neurological dysfunction that have been on benzos for a long time. And then about, 50% of people will end up having a tolerance withdrawal kind of situation at some point in time with their benzodiazepine. And need to taper. So those are things you got to be thinking of when it comes to this picture. So when it comes to best options, I'm always going to say, check your nutrients, support those, and do therapy as first-line treatment for anxiety. And then when we move to conventional things, if we find that you still need some support after, supporting your nutrients, maybe giving you some good doses of magnesium glycinate and maybe inositol or something to help with your anxiety in a nutrient standpoint, then we could look at medications that I talk about. I have several videos, different videos on the benzodiazepine alternatives. So like clonidine, I had mentioned that can be good for someone who has anxiety, a little safer, but they all have side effects, so you have to weigh that in. Hydroxyzine is another one, a little more sedating, so you got to factor that in. And propranolol can also be helpful, depending on the kind of anxiety you have, how often you have, your symptoms. But remember, news alert, anxiety is something that you can't get rid of. You're always going to have anxiety. So you want to learn how to manage your anxiety versus going to a pill as a coping skill to manage anxiety. Because once you start doing that and it's the pill that you're looking for in the quick fix, then you end up not wanting to learn or go through the work that's required to learn how to manage anxiety. And when the pills stop working, then that's where you get into a predicament, and then you have to learn it anyway. So it's best to train your nervous system now, while you're medication naive, to respond to outside ways of parasympathetic, increasing parasympathetic tone, like your vagus nerve massage and your deep breathing and those types of things. So that way, when you need it in an emergency for an anxiety attack or something like that, you're better able to tap into it versus waiting until medication stop working and now you're in this dysregulated state. Now you're trying to calm your nervous system down. Your body and brain's gonna be like, what are we doing? You got to, do it while you're medication naive, and build up those skills. However, not saying you can't build them up later on. You can. It's just a little more challenging to do so in that regards. Okay. Hello, Skelly MC. If vortioxetine only works for low mood and brain fog, but not with anxiety symptoms, okay, what would be good add-on for vortioxetine for anxiety? Yeah, vortioxetine is going to definitely help with depression and can help just for some with GAD. And I'm trying to think, I think you could add buspirone to vortioxetine. I'm just trying to recall. I believe there is a, is it a CYP? Trying to think if it has a inhibition of vortioxetine metabolism. But if it is the 2D6, buspirone doesn't go down that pathway. It's primary, it's 3A4. So I'm pretty sure you could combine those two, buspirone, to get more of the serotonin, because buspirone is like a serotonin partial agonist. So you can kind of help to modulate that more, which will help more for the anxiety symptoms versus the depression. So that is one that you could add in there to try to leverage that. When I work with patients, I don't like to do this combination of stuff a lot. I like to work more in the capacity of finding out what's going on under the hood and doing nutraceuticals and supporting them with diet, nutrition, and lifestyle changes. Which is why it's not top of mind of like what I would add in there, because it's not something I don't like to add things in the mix of patients. But you could try buspirone and see if that works. You could try those others that I talked about, clonidine, hydroxyzine, and propranolol. I don't think there would be interactions there, but just make sure that you're looking for potential drug interactions of those medications before. So do your drug interaction check. And we have a link to the drug RX drug interaction checker. And it's a free drug interaction checker and gives a lot of good information on the medications, and also looks at food interactions that could be potentially a problem. But yeah, you could look at those factors, but I would also look at supporting your nutrients and making sure that you have enough magnesium, because magnesium could be a good add-on here for someone to help with anxiety symptoms. Magnesium glycinate starting at 200 milligrams twice a day, and then you can increase as high as 400 or 600 milligrams twice a day. Really, research studies go as high as 1,200 milligrams in a day. But starting at like a 200 twice a day, and then 400 like that until you get effectiveness of magnesium glycinate is one that I prefer. L-threonate, a lot of we talk about crossing the blood-brain barrier, et cetera, and being more helpful in that regards, and can also help with a lot of brain fog symptoms as well. But I find that magnesium glycinate can be just as helpful, and it's not as pricey as the L-threonate because of the patent and everything on L-threonate. So, a good add-on if, I was looking at non-conventional ways, would be like a magnesium glycinate could actually help you. And then using your skills, like I mentioned earlier, about getting that nervous system into more of a parasympathetic state and increasing parasympathetic tone, because we all live in this world that, our sympathetic nervous systems as a whole is way up here and needs to be toned down. So we all can benefit from vagus nerve exercises and helping increase parasympathetic tone. So make sure to watch that video on the vagus nerve, so you can get some insights there on all the benefits of the vagus nerve and all the things you can do. Okay. Z Pro, I'm not gaming. Okay. How are you? I'm good. You're from Bangladesh. Okay. I have taken many types of mental medicines from the past 3 years, taken all of them, but I'm not getting full results. My problem is MGD, PTSD, BPM, OCD, and anxiety. So you got a lot going on. The amount of medicine I have taken and seen by a doctor, I mean, I don't want to take medicine anymore. I don't want to live. I'm taking so many medicines and there are many side effects. Definitely want to talk to someone when you start having this whole saying you don't want to live. That's an emergency. So anyone out there who's dealing with this type of symptomology, you don't want to mess around. I'm not sure the protocols in Bangladesh, but here in the United States, you can walk into any emergency room and say that, you don't want to live, you're feeling suicidal, and you will get help right away. Um, and so I'm not sure if that's something that's available to you, if there's a crisis line in Bangladesh, because that's something else we have here in the United States, 988. Very simple number to remember to get in touch with a crisis counselor that can help you if you're having these types of feelings. If you're in Bangladesh, they may have a similar type of call to help. So definitely, get in touch with someone in your country that can help you, because this is not a good place to be. And when you're coming, you've tried all the medicines, you start becoming hopeless and you start losing hope for things. And what I have to say about that is that medication isn't the only way. And so I don't know how they do the treatment in your country in Bangladesh. I don't know if they have providers that understand how to do labs and look for other things that could be going on. But I would want to be curious about that and see what else is going on there and support you nutritionally if that's available to you. But first and foremost, I think you need to talk to someone, get into therapy, with someone who can help you with the thinking process and those negative thoughts. This "I don't want to live" type of thinking, very dangerous, is an emergency, and can lead, obviously can lead to someone committing suicide. So we definitely don't want to ignore that. And you want to talk to a professional who can help you get out of this crisis state. Um, you know, Speaking as far as, the thought process that is behind why you don't want to live, and helping you to overcome that. I think that's trumping anything else here in this whole clinical picture that you've presented. So anyone out there, you're in my prayers. Obviously I'm a believer. I'm a Christian. So, you're in my prayers, and I believe in that. But I also believe that you need to get to see a professional, call a therapist, call a crisis line in your area to get some help to talk about this thinking process. Where's this not wanting to live? Where's that coming from? And help to try to resolve that, so it doesn't you don't end up going to the other side, which you can't come out of, right? So I'm going to be praying for you. Kim C. Hi. My son Steven saw you a week or so ago. I spoke to you then about my son in Texas who is interested in labs, and he spoke to his doctor who is for it. Go ahead and do it through your YouTube video, and then schedule an appointment with you after results come in for the coaching since he's in Texas. Oh, I think you're talking about the mental health labs. Okay. So yeah, so I'm a provider in Florida, and I can't prescribe, like, order labs to patients and other, that requires a prescription, et cetera. So a workaround is on the mental health labs video. I think there's a link there to the mental health labs page where you can order them through Rupa, and they actually have a provider who will order those labs, and I have them kind of set up as a package. So they're set up as the mental health labs basic and mental health labs ultra, and then you can add in a consultation after that. So then once you do them, it's a lab kit. So the lab kit gets sent to you, and then in that email that you get from Rupa, there's going to be a link with, in your area, who can draw those labs. So here in Florida, a lot of the labs are like Any Labs Now will do it for like $25, $40, depending on where you go. So you could just go there and find, and there's some mobile phlebotomists that they'll also have listed. So by your zip code in your area who could come. Now the mobile phlebotomists are pricey. So that's why most people just go to one of these lab areas that they'll send you to. Some urgent cares will do it too. So once you get that kit and you find out the lab that's near you and you take it to them, they'll draw the labs, they'll mail it out, and then the results will go into the system. So you'll get a copy of your results into your portal that you get through Rupa, and then I'll be able to see them as well. And then we can do the consultation based off of that. And I can help you, obviously just using education-based knowledge on where you're at, what lab, and then what could be required. And then you would have to go through your provider, to make sure that those recommendations are safe, and go through the provider. So that's how the mental health coaching thing would work. I couldn't basically like take the whole case on and be the sole person like recommending things and this, that, and the other. You have to always make sure you're working with a provider who understands that you're using someone like me, a mental health coach, in that aspect. That's how I would be functioning, as guiding you and basing it all on based off of these things. And I always provide like links to articles and things like that on what you should do. And then you would take that to your provider and then make sure that it would be safe for him. So yeah, you could certainly do that. If your provider is not comfortable with ordering those labs or understanding how to read them, that's what typically they'll do, is they'll want to refer out to someone like me who can do that, who can understand it. And then I can kind of give you the rundown and give you a full report on what's going on in that regards. So yeah, so you could do that certainly. And there should be a link on there, on that site, on how to order it. And then once you order it, then I'll get it. And then I'll have your email and all your contact information, so we can set up the consultation after the results come in. All right. Eva Gelia. Okay. Sorry, I'll just call you Eva. I was taking mirtazapine Remeron 15 milligrams for a year. I switched to liquid form and I did a slow 8-month taper. I'm now at 0.15 with a few mild withdrawal symptoms. Is it a safe dose to stop? 0.15. It depends on the receptor occupancy. Mirtazapine isn't one that I commonly tape. Actually, I have the book here right now. I would want to say that 0.15, it might be. If we go into Maudsley, I have the Maudsley Prescribing Guide here. Let me see what they say about mirtazapine as far as coming off of that, what their drop off, because it's going to depend. Let's see, how long were you on it? You were on it for a year. Okay. It depends on if you're doing a slow or moderate taper. It sounds like 8 months, you're probably moderate. Mirtazapine. Here it is. So it looks like oh yeah, 0.8. So yeah, so 0.15, it looks like would probably not be a good one to jump off of. If you're doing like a moderate taper, you'd want to get down to your 0.15. Actually, yeah, that's because 0.3 is where they drop off of on that one. So yeah, it should be. Let me see the slow taper. Yeah, the slow taper 0.15 is actually the last one, and then they drop off. So that's even at the most conservative one. So yeah, you could actually come off of 0.15 according to receptor occupancy. At that point, receptor occupancy is only 0.9% receptor occupancy. So yeah, so 0.15 is what they're showing here on the most conservative taper plan. And what I'm referring to is the deep prescribing guidelines. So this book here is only like $40. It's one of the books I recommend. I have on my website the books that I recommend. This is like the number one. This just came out actually this year, but how Dr. Horowitz does it is he calculates the receptor occupancy. So how the medication is actually what the percent of how the medication is, the percent that it's actually occupying in those synapses and working in the brain. And that is how he does the taper schedules. And then he does like a fast taper, moderate taper, and slower taper. And on his slowest taper of mirtazapine, his last drop off point is 0.15. And then after that, it's 0. So it looks like it should be safe to come off of from 0.15. All right. Hello, I'm living a dream. Thank you for the super chat. Oh, I forgot to do my super chat thing. I have a super chat thing, but I forgot to put it in here. Anyway, thank you for the super chat. You have been a great resource for people who struggle with mental health conditions. Thank you. Well, thank you. I really appreciate that. That's very, very nice. And yeah, I try to do my best, and I'm going to keep, having videos. My next video, Caplyta, is one I'm working on. I have had several requests for that video, and Depakote, I've got a few on the list that I'm working on. So yeah, so I'm going to keep bringing these types of videos to you so that you can learn more and make an informed decision. That's the main thing. Unfortunately, providers nowadays do not have the time to really give you all of the details about medications that they're prescribing to you. And so that's why I created this channel, is to, get that information to you in easy to digest, hopefully. I try not to get too sciencey, but sometimes you kind of do, to explain how things work and etc. But just trying to, give you that information that you can't get from your provider. And it's not that your provider doesn't know it or doesn't want to give it to you. It's because they're strained for time. It's just the way our model is for healthcare in general, with insurance and the time constraints that we're given and those kinds of things, which is why I don't work under the insurance model. But anyway, most providers do. And so yeah, that's why I have this channel, to help bring that information to you as the patient so that you can, make informed decisions. So thank you so much. I appreciate it. Patty Langasi, hello. I'm also on clonazepam 0.5 for 6 years for vestibular dizziness and anxiety. Can a functional med doctor help? Of course they can. So yeah, because you were mentioning the other things that you were doing with your health anxiety. Yeah, so the providers listed there are going to be psychiatric nurse practitioners are on there, like myself. There's going to be doctors on there. So yeah, and we can prescribe as long as it's within their, some providers just stay away from controlled substances, and that's their right. We don't have to prescribe controlled substances, and that's what clonazepam is. It's a controlled substance. So there are some providers who just stay away completely from prescribing them. But yeah, if that's something you're prescribed, but you're having, the health anxiety and you want to do nutraceuticals and those kinds of things, you can certainly, someone can still work with you in that capacity, whether or not, they need to prescribe this for you. It sounds like you probably already have maybe a neurologist prescribing that medication for you. So it's probably not even a factor. But even if it was, the people who are listed on there are providers like myself that, are licensed to prescribe. So as long as they're able to or willing to, I should say, prescribe controlled substances, you just have to call them and find out. If you're getting it already prescribed by another provider, it shouldn't be a problem on whether or not they can work with you. They should still be able to help you. Okay. Where in Florida are you? I'm in Sarasota. Yes. So I am located in Vero Beach, Florida. That's where my office is. So if you need controlled substances prescribed to you, you would have to see me in person at least once to meet the requirement for the DEA. So you would have to make that trip one time. If you're just looking for um, recommendations based off labs, doing a functional approach and all that, and you have someone else prescribing that Klonopin for you, and that's not an issue, then we can do all of the visits via telehealth. But to satisfy the DEA, I have to see you in the office at least once. So you'd have to make that hike to see me for the initial visit if you needed me to prescribe that clonazepam. And if you've already heard me right now, I'm going to hand you that very detailed informed consent about it as well. But anyway, yeah, you can certainly work with me. And if you just wanted to do the functional lab approach and work on nutraceuticals, diet, and all the things that I do with people as far as that goes, then yeah, we could do everything via telehealth and via video call. So it's through Lighthouse Health Group. Let me give you the number. I don't have it off the top of my head. Let me see. I could put it in the chat, I guess. You could call Lighthouse Health Group. It's 772-226-5368. That's Lighthouse Health Group number. So you can call them and set up an appointment with me, depending on what your needs are. Okay? I would love to work with you. All right, so we'll answer a couple more questions because I'm at the 2-hour mark. My doctor gave me oxazepam, but it is so weak it barely does anything to my anxiety problem. How do I get diazepam? Well, you would have to talk to your provider about it. There is also the Ashton manual, which goes over how to basically take oxazepam and convert it and do a crossover to diazepam. Now, what she's doing is using diazepam to taper off of. You could still do the crossover to diazepam, and then if you want to stay on diazepam, if that's something that you need and it's helping you, then you can do that. It certainly is going to be longer acting for you. Just need once a day dosing. And yeah, I agree. Oxazepam is going to be not as strong as the diazepam, but also make sure that you are doing some of the work for the anxiety too. Like I mentioned earlier, I hate for patients to get so dependent on taking a pill to treat anxiety, because anxiety is something we all must live with. We can't get rid of anxiety. And so I really hope that you're doing some of the skill work and working with a therapist, or learning some techniques on how you can manage your anxiety versus always reaching for a pill to try to get rid of it. Because if that's the mindset you're doing it for, and as you're always going to need more and more, and you're eventually it's going to stop working, and then you end up in this very, very bad predicament that I talk about in the benzo-induced neurological dysfunction video, or you end up in a tolerance withdrawal state and all these things that can happen. So it's important that you understand that. But yes, you can safely cross over from oxazepam to diazepam. And yes, diazepam is going to be it's going to be stronger. So you're going to need, you only need a smaller dose of it, because dose to dose is different as far as the equivalency. And you can use like something like the Ashton manual to help guide you through it. If you want to know the actual conversion, you can use benzocalc.com, I think it is. It's a benzo calculator that you plug in like your dose of oxazepam and say you want to switch to diazepam, and it'll tell you like what the dosage would be that you would need to get that equivalence from oxazepam to diazepam, and then talk that over with your provider. So it would just be talking to your provider about switching from oxazepam to diazepam. So in order to get it, you would need a provider to prescribe it for you. So hopefully your doctor could be open to something like that. I'm not sure. I don't know who your provider is, but that might be something just to kind of put on the table and say, you know, I'm thinking about, you know, I would like to switch to diazepam. Is that something you could help me work on doing to, you know, for it to be more effective because it's longer acting? So, all right, let's do another question. All right, so this will be my last question. All right, Peacock Maiden. I take Lyrica for neuropathy for MS. I have been taking it for 5 years. I've never heard of the problems with the taper withdrawal. Oh, okay. I don't mean to scare you. You've been taking it for 5 years, so that is long-term use. You just need to be aware of it. Like I mentioned, I showed this book here. It has the gabapentinoids, you know, here. So it has a whole section on Lyrica. It talks about the risks of it, the percentages, the different research articles about it. But yes, there are people who have problems with tolerance and dependence. And then if they need to taper off of it, you know, can develop some of this benzo-induced neurological dysfunction. So it's all about knowing your risk, where you're at on the dosage scale. If you're developing that tolerance dependence, if that is something that's happening to you, you know, then have a conversation with your doctor about it. But if it's helping your symptoms, if it's helping your neuropathy, and you're not developing that tolerance dependent state, then, you know, obviously you're not one of the 20%. Now, when it comes to the 20% for benzo-induced neurological dysfunction, I don't believe they include gabapentinoids in that survey. I'd have to go and look. I believe they just included the benzodiazepines and Z drugs in that study. And the Z drugs are the Ambiens, like Zolpidem, Zopiclone, which is like Lunesta, S-Zopiclone. So those types of medications. I'd have to double check that survey to see if they did include the gabapentinoids. So I don't know that 20% is the risk for the gabapentinoids. And I'd have to look at what Horowitz says in that section for Lyrica to see if he gives any percentages of risk of what that would be. But that would just be something to be mindful of, maybe talk to your provider about, so that you can have that conversation of risk versus benefit in your case, because everything's individual. So my goal is not to scare people when I talk about the risk. It's just that you know that the risk is there, because it is pretty bad when someone goes through it. Like I said, I wouldn't wish it on my worst enemy. And my patients who are in that bind state are the most difficult. They're the ones that it's very difficult to help them, because a lot of the stuff they just have to go through, and there's not much I can do to help them. So I never wish that upon anyone. So if I can help prevent it from happening, that's always my goal, is to prevent it from happening. And so preventing it from happening means trying to not prescribing these types of medications for people as first-line treatment, right? And having them use other skills. But these medications, especially gabapentin, pregabalin, like Lyrica, their use isn't for anxiety, right? Their use is for neuropathies and pain related to neuropathy and those kinds of things. And so that's why I don't prescribe it at all, because I'm not a neurologist and I don't, handle patients. If patients have neuropathy and that kind of thing and they need pain management, I refer them to their neurologist. It's out of my scope. And I don't use these types of medications off label for anxiety. So that's just my stance, because I want to prevent that from happening, period. But yeah, my goal isn't to scare you. It's just to make you more informed about it, about the risk, and also that there's things that you can do. And with MS, if you haven't heard of the WALS protocol, WAHL WALS protocol, she actually works with patients who have MS, or she came up with this protocol for autoimmune conditions, but she started out with patients with MS specifically and really helped them with nutrition, really dial in their MS symptoms. So, that could be something else you can do so that you don't have to depend on something like Lyrica for your neuropathy pain. So perhaps utilizing that. So I would look into getting that book, The Walls Protocol. It's available on Amazon, and look at as far as supporting your MS with really good nutrition and diet, to help with those symptoms. So that could be a glimmer of hope there, right? All right, so let's leave on that positive note. And as far as questions that have not been answered, so I sent a newsletter last month with some questions that weren't answered. So I will go through the questions that haven't been answered. I answered 4 questions last time, so depending on the time I have to answer some questions, and then I'll put them in a newsletter. And so whoever signed up for my newsletter will get that and get the answers to the questions in that format, via like a blog post that I have in my newsletter. So yeah, so that wraps up for today. I appreciate everyone for coming here and spending your time with me. I really appreciate that you guys take the time out to learn more about your mental health. And yeah, don't forget to hit the like button while you're here, to help get this information out to others, because it is recorded. And so there'll be a replay of it if you wanted to refresh yourself, on some of these answers to some of these questions. And then I've been starting to break down some of these into clips, so to make it a little easier to kind of go to the exact questions. So hopefully you guys enjoy that as well. So you don't have to try to go through a full 2-hour video just to find a question that you're looking for. So yeah, I'll do another live next month. So I'm actually doing one for members lives next week. So if you want to be a member, you get exclusive lives for you. That's going to be on July 6th. So it's the first Saturday of each month. I do the members live, and then I do the what's the other live? Oh yeah, the live. So this one was late. So I usually do the second week of the month. And the reason this one was later was because for the public live was because the one on the 15th, there was an issue with streaming it to YouTube. It wouldn't allow me. I was sitting here trying to figure it out, Raul and I, and it didn't work. So we had to reschedule. So yes, my next live for July is going to be on the 13th. Yeah. So that's the second Saturday. So as long as Raul is cool with that, it'll be on the 13th, July the 13th. And then the first Saturday of the month is my live with the members only. So yeah, absolutely. We'll be doing another one then. I'll make sure that you guys get that information in the posts. So and if you put your notifications on, that's another thing. If you put your notifications on, you'll get notified when I schedule the next live, so that you can have a reminder for it if that's something you're interested in. Okay? All right, cool. I'll look forward to seeing your email then. All right, wonderful. Thank you, everyone. You guys take care, and we'll end the live here now. Let me get my end live stream thing on, because I think there might be a delay on the live. Let me just do that. All right. Take care.